are delivered in the mesoderm by electrophoresis. The solutions have various combinations like procaine, Trental, and also very popular is CPK, which is creatine phosphokinase, but very effective, but it is banned in Europe. It is still widely used in North and South America. The therapeutic uses of mesotherapy are to eliminate cellulite, to promote weight loss, anti-aging benefits, to eliminate localized fat deposits. Mesotherapy helps to improve blood flow, dissolve excess fat deposit, remove the fibrotic hardened connective tissues, smoothen skin. There is a gradual loss of inches, enzymatic cellulite improvement, lipodystrophy, irregularity correction, and skin elasticity enhancement. These are some of the results of non-surgical treatments. Of course, this is not after one session, but this is a series of sessions in which we have done fat lysis with the help of high-intensity focalized ultrasound. And in some areas, when the patient starts losing fat, you need to tighten the skin with radio frequency and laser as well. These are some of our own patients after about 2 to 6 sessions. Sometimes they have also required more than 10 sessions. This is an abstract of the paper presented. I had presented this paper at Westfield Summer School in Cambridge, UK. There was a comparative study of non-surgical obesity treatment on patients with different ethnicities. We had done a series of clinical trials and studied average loss in centimeters at waistline in different patients: Arabic, Americans, Canadians, Egyptians, French, Indians, Italians, Lebanese, Pakistanis, Syrians, Spanish, and Tunisians. And the results after 1 session were noted, and also average reduction in the total body fat percentage was also studied. It was observed that average reduction in the waist circumference after 1 session of lipolysis was 2.029 centimeter, and reduction in the total body fat percentage was 1.1375%. It was concluded that a combination of non-invasive fat loss treatments of high focalized intensity ultrasound, endomology, mesotherapy, and laser resulted in the reduction of resistant fat, which does not go away with current treatment modalities of diet, exercise, pharmacotherapy, and it also reduced the body fat. After having said about obesity, let's look at why should a physician be concerned about treatment of obesity. Identify obesity as a disease in general population. Don't wait for obesity-related complications like diabetes, hypertension, osteoporosis to set in to start the treatment, which most physicians do because they are so busy treating the problem which the patient has come to us with. Care and concern for the patient will help boost confidence for the physician and develop a good relationship as a healthcare provider. I think this is very important so that the patient is more likely to remain with you for a longer time in future. A sort of retention of your patient, specifically I would say for general physicians. Since obesity affects almost all the organs in the body and all systems, whichever specialty physician you are, I think it concerns you in some or the other way. Like cardiologists, yes, there is obesity-related risk of angina, myocardial infarct, CCF, high blood pressure, cholesterol, TBT, and embolism. And endocrinologists obviously will come across diabetes mellitus, PCOD, menstrual disorders, infertility, complications during pregnancy, birth defect, and intrauterine fetal death. Neurologists will encounter stroke, migraines, carpal tunnel syndrome, dementia, multiple sclerosis. Today, I think psychiatrists deal mostly with cases of depression in women. I'm not saying men are depressed, but yes, that is what the statistic says, and social stigmatization. It remains to be seen whether obesity is causing depression or depression is causing obesity. Rheumatologists deal with gout, poor mobility and osteoarthritis, where they tell patients to reduce weight only when the patients come to them with osteoarthritis, and then it gets very difficult. Dermatologists with stretch marks, cellulitis, a gastroenterologist with, yes, a reflux, fatty liver, and bile. Oncologist with, yes, obesity increases the incidence of cancers. And a chest physician obviously is going to encounter with sleep apnea, obesity, hypoventilation syndrome, and other increased complications during general anesthesia. And urologist and nephrologist with erectile dysfunction, urinary incontinence, and chronic liver failure. Are physicians slow to address the obesity problems? Almost 90% of the doctors feel that it's their responsibility to help patients lose weight, yet 72% said that no one in their practice has been trained to deal with obesity and weight-related issues. Only 39% of the obese adults were ever told by a doctor or the other healthcare provider that they were obese. Of these, 90% were told to lose weight, but 1 in 3 said they weren't given any guidance on how to do it. The failure to address weight problems, so-called clinical inertia, may be caused by doctors' views on obesity, stigmatizing attitudes, belief that patients won't try, lack of confidence in their ability to treat obesity, lack of effective treatments, and poor reimbursement for providing them. So what is the role of physician in an anti-obesity campaign? Yes, a physician, I feel, generally plays a big role in the total overall health and fitness of the community. He can influence positively by treating or at least motivating his patients, family, friends, and community at large. So how does a physician go about addressing this issue in a community, and what is an overall guide to your patient's weight issues? Monitor weight over time. Physicians can make this a rule in their clinic that any patient who walks in, whichever problem it is, they can have a regular weight check. Motivate their lifestyle changes, define success differently, and take a team approach by referring them to dietitians, exercise specialists, nurses, etc. Is physician a role model? Diabetes and obesity are the most common lifestyle-related ailing to the doctors. Working for long hours and tight schedules do not allow doctors for any physical activity, and no exposure to sun, so lack of vitamin D3, and erratic lifestyles and eating habits do add to the woes of medical practitioners. Can an obese physician be a role model? Studies show that it's more difficult for obese physicians to give a credible medical advice when they do not follow it themselves. Patients' confidence scores are very low from patients receiving health counseling from physicians who are obese. Physicians with poor personal lifestyle habits are less likely to counsel patients with healthy lifestyle. Physicians who are obese are less likely to diagnose obesity in patients. Yes, so you have to practice what you preach. These are some of my photographs where I am practicing what I'm preaching. I recently started with marathon training and I did my first half marathon in Delhi, and some of my trek photographs. So all of you can take some sort of fitness regime and put it in your schedule where you can take this pose or any activity which increases your metabolic rate, and you can practice it every day. Physical activity, a dietary modification. I know mostly the surgeons, anesthetists and intensivists, they do not have the time to eat on a regular schedule, and then you tend to binge on certain unhealthy foods. So let's try to avoid that. A stress management is a must for all doctors because they are managing stress in their own patients. No smoking, no alcohol, and maintain a healthy BMI. So some of these suggestions to the policymakers are Obesity awareness should be in school curriculum with compulsory emphasis on health and fitness. A few days ago, there was a news by Professor Duncan of the famous Duncan diet. He had urged the France government to give extra marks to children who are in the range of a healthy BMI. So that would start with a healthy lifestyle from childhood. Degree and diploma courses in pediatrics medicine by the university. Government should start anti-obesity campaign like a family planning campaign. National level obesity prevention program should be initiated similar to AIDS prevention, and amendment in the laws and budget for commissioning healthcare and resource allocation for obesity. So I thank you all and have a very happy new year, and I wish you all a perfect BMI for 2012. Thank you.
Wait, look at please. Thank you.
Thank you.